our next speaker, who is Professor Harry Iland, to share his screen and join us. Professor Iland is a clinical professor at the University of Sydney and perhaps known to some of you as a haematologist who used to practice clinically at RPA. His major clinical and laboratory passion has been in the investigation and management of a leukemia called Acute Promyelocytic APML, I know it as, and Harry's going to talk to it. But he has been quite a champion for this type of leukemia. The research group that Professor Ho mentioned, Australia's Leukemia and Lymphoma Group, Harry has actually led the majority of the work in regard to this leukemia, and we're very proud to have called him a colleague for so many years. So Harry, I'd like to invite you to present your session on acute promyelocytic leukemia, making a good treatment even better. Thank you.
Thank you very much, Tracy. Can I just confirm the slides are in the right position and so on?
Yes, they are. Thank you.
Thank you. Well, welcome everyone, and thank you for joining. And I'm going to tell you a story that's almost as old as I am. So when I first started out in medicine, leukemia was pretty simple. It was classified into just four broad groups, where, depending on how it presented. If it came on very quickly and was a very aggressive leukemia, it was called acute leukemia. And if it came on more slowly and took a long time to cause problems, it was a chronic leukemia. And then there were myeloid leukemias and lymphoid leukemias, depending on the cell type. And that's pretty much how it was initially. But in 1957, this Dr. Hillestad published a paper on a new type of leukemia. He called it, it was a type of acute myeloid leukemia. He called it a special type, and he described it in this way. It had a very rapid fatal course, patients dying with only a few weeks. The white blood cells looked different. They were dominated by promyelocytes rather than the blast cells, which are even more primitive cells that you see in acute myeloid leukemia. And the patients had a particularly severe bleeding tendency. And he suggested naming this acute promyelocytic leukemia, and that's the name that has stuck to the present time. And he commented that it seems to be the most malignant form of acute leukemia. So let's have a look at the things that alerted him and things that we've learned in the subsequent 60 years that confirm that this is a very distinct subtype of acute leukemia. So the cells look different under the microscope. On the right-hand side, you can see the blast cells that are typically found in most acute myeloid leukemias. On the left, you see these promyelocytic leukemic cells. They either have lots and lots of granules in them, or these little rods. Don't know if you can see my pointer, but these rods that cover the cell. And sometimes they have a very indented nucleus, either with no rods or maybe just one rod. So they look different. As Dr. Hillestad said, these patients have a particularly severe bleeding tendency, and that's because the cells contain lots of chemicals and proteins that are important in the clotting and bleeding, normal clotting and bleeding processes. So when these cells start to appear in large numbers and they start to die, they release lots of these chemicals, and that causes excessive activation of platelets and clotting factors. And that in turn starts to cause clotting, but it happens so quickly that the person will then starts to run out of platelets and clotting factors, and that in turn causes bleeding. The platelet count's very low because the bone marrow is full of leukemia. And these cells also release chemicals that degrade the clots and degrade the clotting factors before they can even cause clotting. So the net effect is that these patients tend to have a dramatically increased bleeding risk and also an increased clotting risk, which is an unusual combination. And this is typified in this survival curve from the Australian Leukemia Study Group, which was the precursor of the Australasian Leukemia and Lymphoma Group. This was a trial conducted in the 1980s and early 1990s. And this is the survival curve. And a survival curve basically plots against time the proportion of patients who are alive at any one time. And you can see the survival curve goes from 100% down to less than 80% within just a few weeks. And that we call that phenomenon the early death rate. And it was around nearly 25% of patients were dying within the first month. And that's very much as Dr. Hillestad had described. And then the survival curve kept on going down, but eventually plateaued out at around about 30%. And this is the problem. These people are dying because of bleeding, and particularly bleeding into the brain. And this is a patient that actually of mine, unfortunately, who had this huge bleed into his brain on about day 4 after starting treatment. But surprisingly, it caused very little damage. It interfered with his vision, because that's where that big lump of blood is where the nerves from the eyes go back to the brain. But he got over that, and he in fact survived, and he's still alive in remission to this day, 10 years later. We know that bleeding is the biggest problem, but why is it particularly bad in some people more than others? And we now know that the height of the white blood cell count when the person first presents with leukemia is particularly important. It's the single most important predictor of an early bleeding death, and it's also the single most important predictor of the leukemia coming back, relapse after what appears to be successful treatment. We also now know the genetic basis for this leukemia. So this is a karyotype, which is an analysis of the DNA in cells at a time when they're dividing. When they divide, the DNA contracts into chromosomes, and these are the chromosomes from one cell all lined up and cut out by a scientist and laid out to examine. And you can see the 2 red arrows show chromosome 15. The one on the right is a little longer than the one on the left, and chromosome 17 is a little shorter on the right. That's the abnormal one compared to the one on the left. So what is happening here is a translocation. So you can see the light blue line cuts through the chromosome 15 on the left and the chromosome 17, and the bottom bits of those 2 chromosomes swap over and then rejoin. So it's a translocation of genetic material between 2 chromosomes. And where those blue lines are, we now know that there's a gene on chromosome 15 called the APML gene, and one on 17 called the retinoic acid receptor alpha gene. And those 2 genes get broken by that translocation and rejoin in half of one gene joining to half of the other. And that is a very abnormal phenomenon, and that is we now know what drives this leukemia. Work done over many years has shown us what type of treatments are best available for this disease. John Bernard published in 1973 2 groups of patients, one with using what was very basic chemotherapy initially, and you can see that most patients had resistant disease. Nearly 70% failed to respond, only about 10% got into remission. He also published a group of patients who were able to get access to daunorubicin, an anthracycline type of chemotherapy drug, and they had much better responses. Only about 10% had resistant disease and 40% got into remission, but there was a high death rate during induction, this early deaths, because this drug was so effective, it killed so many cells, it also caused lots and lots of bleeding. 20 years later, Dr. Avasati from the Italian group used another anthracycline, idarubicin, and you can see his results are even better. Only 4% resistant disease, 80% in remission, and a much lower death rate during induction. And that reflects not the chemotherapy, but in fact, the importance of supportive care with platelets and plasma transfusions during induction to control the bleeding that's going on, and also better treatment of infection. Now, we now know that treatment has gotten even better, and we now know a vitamin A derivative is a very important component of treatment for this drug. So this vitamin A derivative is known as all-trans retinoic acid. And you remember that I mentioned that one of the genes that's disrupted in this disease is the retinoic acid receptor on chromosome 17. So it's not surprising that a drug related to retinoic acid, a type of retinoic acid, may have some activity in this disease. And the Chinese group from Shanghai showed that they were able to get complete remission in a fairly small group of patients, but in virtually all patients. And very importantly, the ATRA corrected the bleeding tendency, whereas chemotherapy usually makes the bleeding tendency worse. And they also showed that the remission was not due to the ATRA killing the cells, but it caused them to differentiate and behave much more like normal cells. And so this was quite a different concept in the way to treat a leukemia. And you can see this is serial bone marrow samples from a patient who's been treated with ATRA. On the left are the primitive cells before treatment, the promyelocytes with the granules and the rods. In the middle, after about a month of therapy, the cells are starting to look different, less aggressive looking. And on the right, you can now see much more mature cells. Some of these, I don't know if you can see the pointer, but these segmented cells are basically normal mature cells derived from those original primitive leukemic cells. So this is differentiation of leukemia. The problem was that ATRA caused a syndrome called retinoic acid syndrome, or now called differentiation syndrome, which often happens in people treated with ATRA. They get basically a leak of fluid into the lungs. And you can see the normal chest X-ray on the left with a nice clear heart shadow and the diaphragms and the clear lungs above them. And on the right, the heart looks much bigger. It's surrounded by fluffy pictures in the lungs, and you can't see the diaphragm clearly at all. And so this is a problem when people treated with ATRA, but unfortunately it can be controlled both with cortisone type therapy, prednisone, and chemotherapy also reduces the severity of this differentiation syndrome. So hematologists were now finding that they had a bit of a balance problem. We know that they knew that chemotherapy makes the bleeding worse, but helps control the differentiation syndrome, whereas ATRA corrects the bleeding problem, but causes this differentiation syndrome. So the problem was how to combine or what to do about these conflicting side effects. Sorry, just getting my timer. And it came to an Italian group, a cooperative group called GEMEMA, like the Australasian Leukemia and Lymphoma group. The Italians have a group called GEMEMA that put together a protocol based on ATRA and idarubicin, one of the anthracycline chemotherapy drugs, and they did it in a very effective way. They managed to combine this so successfully that, and as this was an Italian protocol, it, needless to say, was given the name AIDA, ATRA and idarubicin. And with this protocol was so successful that it effectively took the hematology world by storm with this triumphal march from AIDA. So many groups adopted an AIDA type of chemotherapy, but there were still some patients who were failing and relapsing. This is data from the PATHEMA group, which is a Spanish cooperative group, and they intensified chemotherapy, and it's called risk-adapted therapy, for patients with the highest risk, the ones with those high white cell counts at presentation. And you can see there's data here from 3 trials, 1996, 1999, and 2005, where showing the relapse rate going down for all patients, but particularly going down for the high-risk patients, because the high-risk patients got the most intensification of chemotherapy. But unfortunately, that came at a cost. And this is data of deaths in remission from 3 different cooperative groups, the Spanish, the Italians, and the French. And you can see that this is people who have survived induction. They haven't had early death. They've gone into remission with either ATRA and idarubicin or some other combination quite like that. But then they've had intensive chemotherapy in remission to consolidate that remission. And some of them have actually died from complications of intensive chemotherapy. And that's particularly a problem for the high-risk patients because they had the highest white cell counts and got the highest amount of chemotherapy. So this is a bit of a tragedy, really, because these are people who probably were already cured but have died from ongoing therapy. So we needed something else. And that fortunately came from a drug called arsenic trioxide. And the story began again in China in the 1970s. A herbalist was heard to be administering traditional Chinese medicine in a place called Indian, and the government heard about this and that he was getting effective anti-cancer results. So they sent a Dr. Zhang from Harbin out to Lindian to find out what was going on. And he found out that this traditional Chinese medicine contained a combination of arsenic trioxide, mercuric oxide, and toad extracts. And with some elegant experiments, he was able to determine that the arsenic trioxide was the active ingredient. We didn't hear much about this in the West until almost the turn of the century, because they published their work in Chinese journals, in Chinese language journals. And so the Western world didn't see anything until this paper appeared in 1997 from the Shanghai group again, in which they showed that this drug, arsenic trioxide, could achieve 90% remissions in patients who had failed ATRA and had failed chemotherapy. And they went on to show that by combining ATRA and arsenic together, that combination was superior to either drug alone. Now, arsenic trioxide comes with its own set of problems. The particular one that we have to watch out for is a cardiac electrical disturbance rhythm problem, where patients are prone to getting a prolongation of the electrical rhythm through the heart, and that sometimes sets them up for this abnormal ECG on the right, which is a ventricular tachycardia. And that is a potentially fatal complication too. But we now know about this, and we know how to watch out for it with frequent ECGs, electrolyte monitoring, avoiding other drugs that can also cause this prolongation problem. Arsenic can also cause the differentiation syndrome like ATRA, but not as severely, and we know how to treat that. And occasionally there are other problems, including occasional peripheral neuropathy that you'll hear about from Tracy later on. So this combination of ATRA and arsenic is now the standard of care around the world for standard risk APL, the ones who don't have a high white cell count. And you can see it was much better than ATRA plus chemotherapy in a randomized study. For high-risk APL, you still need a little bit of chemotherapy. And this is data that we published from the APML4 trial from the Australasian Leukemia and Lymphoma group, in which we combined ATRA, arsenic, and idarubicin, and were able to show excellent results with 95% of patients being alive and relapse-free after achieving remission, regardless of whether they had standard risk disease or high risk disease. And this is now one of the one of the acknowledged best protocols for high risk APL. The final bit of the story is how can we make this treatment better? The problem with arsenic therapy currently is it's given intravenously by a 2-hour infusion every day, month after month, for several months. So if we could put it into a capsule, it would clearly be a much simplified treatment and would reduce hospital resources. And that's exactly what we're testing at the moment. There's no oral arsenic available in the Western world at the present time. There are some oral arsenic formulations in China, but they don't meet the regulatory requirements of the Therapeutic Goods Administration or the Food and Drug Administration or the European Medicines Agency. So we've been trying to document the validity of an oral arsenic that will satisfy those regulatory agencies. This is the trial we put together. We basically took patients who were in remission already from either ATRA and arsenic or the APML4 protocol, and then gave them 4 cycles of arsenic and 7 cycles of ATRA. And in each cycle, in the first week of each cycle, we took lots of blood samples on day 1 and day 4 and measured arsenic levels, both after intravenous arsenic and in some cycles and oral arsenic in other cycles. And the idea is to compare the two to see whether we get the right amount of arsenic in the blood after oral as we do by the intravenous infusion. And this is the sort of data that we see, blood levels over the 5 days of each week that they get arsenic. And we measure the Cmax, which is the maximum concentration, and the AUC, which is the area under the curve in 24 hours, the amount of arsenic that they're exposed to for that whole 24 hours after a dose of arsenic. And these are the results. We've aggregated all the data from the oral arsenic and all the data from intravenous arsenic for all the patients and expressed it as a ratio. And if the ratio is close to 1, then we know the oral is doing as well as the intravenous. And that's in fact exactly what we have seen. The ratios are close to 1 for all the different parameters that we measured. And the confidence intervals, in other words, the reliability of that data, falls well within what the Food and Drug Administration and the European Medicines Agency accept as required for bioequivalence. So we think we've shown that in this APML5 trial that the oral and the intravenous formulations are bioequivalent. We didn't see any unexpected toxicity signals, and we believe the results support the incorporation of the Australian oral arsenic formulation in the management of patients with APL, and hopefully this oral formulation will become registered. I'd obviously have to thank all the patients who participated in these trials, John Reynolds, the statistician, the pharmacologists, Alan Boddy and Haley Schultz, the ALLG, all the investigators and clinical trial teams, particularly Lexi at RPA, the National Measurement Institute and the molecular labs, particularly Shane Supple in my laboratory, who did lots of the monitoring of the leukemia, and Febra, of course, the drug company that make this oral formulation for us. Thank you very much.
Thank you so much, Professor Iland. What an amazing example of investigator-led work in the APML space and the significant survival improvements that you have demonstrated, a 95% remission rate for a type of leukemia that caused death in the majority of people just 50 years or so. A couple of questions. Is toad extract going to make a comeback, do you think?
As far as I can tell, it didn't have much effect against APL.
But it was nice to hear you reflect on, where the improvements could be made when you got to 95% remission. It was focusing on the convenience. The improvements can be made in the convenience of the drug delivery. And so nice to know that oral preparation that seems very close to being there is something that's been driven by your work here in Australia. So you had mentioned, Professor Iland, early on about the important work of international groups, and particularly Gamia and the Italian group early on. Did you want to just comment on sort of the difficulties or challenges or opportunities? It seems that international collaboration is important, and how that works.
International collaboration is important. We tried this APML5 trial was conceived in 2012 when I met with a couple of North American colleagues at the American Society of Haematology meeting, and we designed how we would like to do this study. And those negotiations went on backwards and forwards for years, in fact, and eventually we realized it was never going to happen for lots of different regulatory reasons and lots of complicated reasons. And in the end, we launched the study just here in Australia with the Australasian Leukemia and Lymphoma Group. But they are extremely interested in the data that we are putting out, and very much want access to this drug as well as for routine care once it's approved by a regulatory authority.
Yeah, so perhaps that brings me on to one final question, which is, how does the work done in one country or by one investigator benefit patients all over the world? How does that message, or is it easy for your data to be shared in another country, apply that for their patients?
Certainly, publishing data is how people in different countries communicate very effectively, and we obviously, if data is published and published in a high-quality peer-reviewed journal, then generally you can rely on that data as being translatable to another jurisdiction. The problem always, however, is the regulatory authorities in each jurisdiction have their own set of rules, which sometimes gets in the way of delivering good therapy quickly and easily. So you have to build that into the design of your trials. You have to consult with the regulatory agencies when you design these trials to make sure that what you are doing is in fact the sort of information they want to look at when they decide about registering a drug. Yeah, an important part, I think. Great. So thank you so much. I think we'll now move on to stay on time, and I'm going to hand back chairmanship to Professor Ho, who is going to introduce the next session. Thank you, John.